All right, I think we can go ahead and get started. Welcome. I'm Mike Frederick, Associate Professor and current Acting Chair of the Division of Applied Behavioral Sciences here at the University of Baltimore. On behalf of my division and the university, I'd like to welcome our distinguished guests and all our attendees to this symposium on psychedelic medicine. So here at the University of Baltimore, among other things, we offer a master's degree in applied psychology, and that includes programs that train students to become professional therapists and counselors. So as therapies aided by psychedelic drugs are expected to become more widely available in the coming years, our counseling faculty are interested in exploring how this might influence the types of training that we offer our students going forward. Now, for many years, research involving psychedelic drugs and the potential benefits was largely avoided by most of mainstream science and medicine, but today things are changing fairly rapidly. In fact, I read recently that there are certain mining and extraction companies that have been making more speculative land buys because they've calculated that if the mine doesn't turn out to be as productive in deposits as they hope, they have a fallback of growing psychedelic psilocybin mushrooms in the mines to meet the anticipated growing demand. I don't know if that's a good idea, and I guess I have mixed feelings about it, but I think it's evidence that things are changing. They're changing economically, socially, and legally. So this shift hasn't just happened by itself. It's been made possible by a number of key individuals, including researchers, therapists, policy advocates, and others who saw potential in this area and didn't give up on it. And so we're actually joined by a few of them today. And thanks to their efforts, the conversation has now started to move away from questions like, well, can this be done safely and does it really help people? To questions like which therapies work best in which cases, how much will it cost, and who will really have access. So our speakers this evening have direct insights into the research and clinical trials that have led us to this point, as well as what the future likely holds. The plan for this evening, we have three main speakers, and after each of them, we will have a brief Q&A. So with the webinar format, we encourage everyone to participate in the chat and the Q&A. Panelists will be able to read and respond to that throughout, and then we'll choose a selection. My colleague, Chris Eisel, and I will be selecting a few questions after each talk to present to the speakers. After the three talks, time permitting, we'll have a more general Q&A. To give you an idea of the topics, just in case you have a question in mind, the first speaker, Rick Doblin, the founder and executive director of the Multidisciplinary Association for Psychedelic Studies, or MAPS, will be discussing research and clinical trials on MDMA-assisted therapy. Our second speaker, Matt Johnson, is professor of psychiatry and behavioral science at Johns Hopkins. He's going to be discussing mainly psilocybin research. And then Joseph McCohen, a licensed clinical psychologist, our third speaker, will tell us more about the practice side of this work, how therapists are trained, and why there's a particular need for more therapists of color. And again, time permitting, then we'll have a more general Q&A after that. On hand for that, we also have Wes Hale, who's the training program director at MAPS and knows a fair bit about how therapists are trained in this area. So that is the plan. I would love to acknowledge MAPS, Bob Parsons, President Kurt Schmoke, the College of Arts and Sciences, the Division of Applied Behavioral Sciences, and the University of Baltimore. And with that, I would like to turn things over to the Dean of the Yale Gordon College of Arts and Sciences, Chris Spencer.
Thank you, Mike. That's very nice. It's my pleasure to welcome you to the University of Baltimore and the Yale Gordon College of Arts and Sciences. And I want to extend a very heartfelt thank you to Mr. Bob Parsons, who has been so generous to the university. Since I've been at the university in 2007, he has helped us establish a veterans clinic in the law school. He's been instrumental in our Veterans Center, and I personally met lots of veterans who use that center, and it makes such a big difference to their lives. as they have a place to congregate together and really experience the college education as a shared experience with people with the same experience. It has made a tremendous difference to our students. And then most recently, he has donated a very large scholarship for our students that focus on undergraduates who have gotten their AA degree and military veterans. So I want to thank Mr. Bob Parsons. He's here tonight as a sponsor, and we're very happy to welcome you. And I wanted to just turn it over to you now so you can say a few words, but I want you to know how heartfelt our thanks are for everything you've done. And I know you've been very generous with MAPS as well. So it's all yours, Bob.
All right. Thank you, Christine. I sure appreciate that nice, warm introduction. And the University of Baltimore is very special to me. It's the first time I ever achieved anything academically. And I can tell you that's not because the University of Baltimore, as you know, is not a ride in the park. I worked my tail off to do it, but I graduated magna cum laude. And when I did that, it was after I got out of the Marine Corps and worked at a steel mill for a year. And my parents thought it was the second coming of Christ. But I did it. It happened at the University of Baltimore, and I just loved the place, and I love to help out. And as long as I'm walking, I'll be there supporting the university. But that's not why we're here. Why we're here is we are on the cusp of, well, the only way I can say it is a game changer. And I'm excited that the use of psychedelics we're for the first time thinking of using them in our country as in a clinical setting, and what a difference it makes. When I was 17 years old, I joined the Marine Corps. And by the time I was 18, and this is in 1969, I was in Vietnam carrying a rifle with the 26 Marines. And we were in combat most nights. After a month in combat, I was wounded, and I went to a hospital in Japan. And in the Army, Navy, and Air Force, if you were wounded, you went home. And of course, the Marine Corps, 3 times. So I was sent back to finish my tour, which I did. And then I went home. But when I went home, things were different for me than when I left. I had what I later learned was PTSD. And I got to tell you, it wasn't easy. First, I didn't know what it was. I had at first, when I was home, before I left, I used to like to be in big groups. I liked being around people, but I wasn't like that anymore when I came home. And I had all the classic symptoms. The feeling of no matter who you're with, you just feel like you don't belong. You always want to. You're more comfortable being alone. You don't want to be in groups. Flashbacks, depression, thoughts of suicide, and yeah, I had them. And of course, I've had 2 failed marriages. So PTSD took its toll on me, and it didn't change for me until 3 years ago when I read Michael Pollan's outstanding book concerning the benefits of psychedelics and the promise that they have. And the book is called How to Change Your Mind. Well, when I bought the book, I kind of knew what it was about, but I really didn't. I went through it like a bag of peanuts, and it made me wanted to try something else to finally maybe get better, to make my life easier. So my wife had, through some friends, linked me up with 2 wonderful people who travel all over the world and help people that were in situations like I was in. And so they met me in Hawaii 3 years ago. And during that time, I was given psychedelics, and over a 5-day period, I spent a lot of time in the clinical setting with them, talking me through things and guiding me. And after that week, when I went home to my back home and went back to work, the people I worked with were amazed at the difference in me. Everybody's going, what changed him? Some people were asking, did he find out he's going to die soon? I've never seen him this nice. So it was a big difference for me. And I was like I was before I left again. I wanted to be around people. I didn't want to be alone all the time. My wife actually liked hanging around me again. And so it was just wonderful. And the only way I can surmise what psychedelics did for me is it was 47 years since I returned from Vietnam. And in 47 years, after 47 years, I finally came home. And I got to tell you, it's good to be home. And what happened to me in the way I was able to mostly overcome PTSD needs to happen for everybody that gets that. And that is part and parcel of what this is about. And, having the University of Baltimore involved in this at the forefront of this, if we can get that done, is so many wonderful things will happen. Is we will train many therapists, and most importantly, we will start training therapists of color. And therapists of color, once that's done and this thing gets approved and we're full throttle, is people of color who are struggling with PTSD will be among the first citizens or the first patients that are also going to come home. And for them to be among the first, I'd say it's about time. So this is also wonderful. If I look excited, I'm so excited, I'm ready to explode, but in a good way. So thanks everybody for coming here. And I look forward to the rest of the session. And I just want to throw out a big thank you to Rick Doblin. Rick, every time I talk to you, buddy, it picks me up. So thank you, brother. All right. And I will turn it over to our first speaker. And thanks again, everybody. You know what? It's good to be home.
Thank you so much, Bob, for those wonderful remarks and for sharing that with us. I'm going to unshare this background screen now and allow our first speaker to get set up as I introduce him. So our first speaker is founder and executive director of MAPS, the Multidisciplinary Association for Psychedelic Studies. He received his doctorate in public policy from Harvard's Kennedy School of Government, where he wrote his dissertation on the regulation of the medical uses of psychedelics and marijuana. Additionally, Rick studied with Dr. Stanislav Grof and was among the first to be certified as a holotropic breathwork practitioner. His professional goal is to help develop legal contexts for the beneficial uses of psychedelics and marijuana, primarily as prescription medications, but also for personal growth for otherwise healthy people, and eventually to become a legally licensed psychedelic therapist. He founded MAPS in 1986, and his organization has been instrumental in bringing about the current renaissance we're experiencing in psychedelic research today. So it's my great pleasure to welcome Rick Doblin.
Wow, Michael, thank you so much for having me. And Bob, that was so inspiring, your opening talk there. That was really moving. I'll just share that I was a draft resistor for Vietnam, planning to go to jail and to object to the war in that way. And so I was traumatized in a different way. But now I think I feel just so right about trying to help veterans and trying to help others who have been through that, and also trying to bring the therapy to marginalized populations, to people of color, to everybody who needs it, not just in the US, but around the world. And so what I'm going to do is I do have a slide presentation to share. It'll be kind of a summary, a bit of the MDMA PTSD research and a little bit of future things that we're going to do. So I will share my screen. It'll take me maybe just a bit of a second to do this. Okay, sorry, just take a second here. Okay. Let me also just share that I've been incredibly inspired by Kurt Schmoke during the 80s when I was working on starting MAPS, and also he was when he was mayor of Baltimore, he was really the first African American to come out strongly in favor of drug policy reform. And it was just so great to be reunited to talk to him about this approach as well. I'd like to start by talking about my mentor, Stan Grof, who is the world's leading expert on LSD research. He's a psychiatrist from the Czech Republic. Back when the Russians took over Czechoslovakia, he came to the United States in '68, and then he was at Johns Hopkins and helped lead the LSD research there. And he said, psychedelics are to the study of the mind what the microscope is to biology and the telescope is to astronomy. And it brings things that are previously difficult to see into our vision. And just like the telescope was used to understand our place in the universe and how that was controversial, and Father Bruno was burned at the stake by the Inquisition for saying that the Earth wasn't the center of the universe. Galileo died under house arrest. Now the telescope has been accepted, and it's seen as kind of a neutral tool. And the same is what I'm hoping will happen with psychedelics, that it has been controversial, but I think that was more for cultural factors, particularly during the 60s. And I think that now we really are at a place where our society has matured to the point where we could successfully integrate psychedelics. Let's see. Now, this slide I'm showing in order to demonstrate a psychedelic looking slide. You got this brain on psychedelic drugs with all those colors. But this slide was created by the FDA for a presentation that they gave a little bit less than 2 years ago at a conference. And not only that did they present their talk, but they said that they're going to develop what's called a guidance document to help researchers develop drugs through the FDA. So we feel that the FDA is now a partner in research, and they really want to see it. We had a big meeting with FDA yesterday about our research that I'll show you, about how to proceed to the next steps, which is towards applying to become a MDMA-assisted therapy for PTSD to become a prescription medicine. So it was a productive meeting yesterday. And as kind of evidence, though, of the impact of what the FDA has done here, this is a graph of the number of papers on psychedelic research that have been published in scientific literatures. And if you can see, there was a peak in the 60s and 70s near the end, and this was quite a lot. But then it diminished almost to nothing, and then it started to growing up. So it took around 30 years for it to get to where it was before, and now the numbers of papers are just exploding. So it's just a wonderful situation now that the research with psychedelics is really in a renaissance all over the world, not just in the United States. But I would say that the key thing that made it happen was the FDA, starting in 1992, where they formally decided to permit psychedelic research to begin again. Now, this is MAPS's corporate structure. Just to say, MAPS I started in 1986. It's the nonprofit organization, and it's been 35 years. But 6 years ago, a little bit more than 6 years ago, in December 2014, we started the MAPS Public Benefit Corporation, which is the pharmaceutical arm. And that's the group that will do the research and eventually get permission to, we hope, to market MDMA. We will market MDMA at a profit, but a reasonable profit. We're going to maximize public benefit, not profit. And the reason that we're going to do that is so we could tell donors like Bob and Renee that they don't have to keep funding us forever as we do more and more research, but that we're a rare nonprofit, that we have the possibility of a product to develop, which is a pharmaceutical medicine. And if that does happen, then we'll use the profits to further the research. So there's no personal ownership. MAPS is the 100% owner of the MAPS Public Benefit Corporation. When people donate to MAPS, they get tax deduction, and then MAPS puts the money into the Benefit Corp. The Benefit Corp does the research. And we're about 105 people now. About 2/3 work at the Public Benefit Corp, which is led by a group of women who used to work at Novartis. So we call them our refugees from Big Pharma. And then another 30 or so work at the nonprofit. What permits this is called data exclusivity. So Ronald Reagan in 1984 signed this law to provide incentives for developing drugs that are off patent. And so what it means is if you make a drug into a medicine for a period of what will be around 6 years, no one can use our data to market a generic, but they can create their own data. We're not trying to patent it or block anybody else from doing it. But in Europe, it's 10 years data exclusivity. So these are powerful incentives to develop drugs, even though they're in the public domain. This is MAPS. We have all sorts of functions, the policy and advocacy team, our fundraising team, our harm reduction, Zendo project, where we do psychedelic harm reduction at events, and also are trying to teach the public more communications and marketing, accounting, finance. This is just a brief sense of what MAPS is. And then all these functions of our Public Benefit Corp. So the results that I'm going to tell you are really the results from a relatively large group of people. Now, for a pharma company, this is trivially small, the number of people we are, but we've been able to accomplish an awful lot. Since its founding in 1986, we've raised over $100 million in donations. And we will end up spending $75 or $80 million to make MDMA into a medicine for PTSD. So that's why you could see that we wanted to find a way that we're not constantly asking donors for more money. What I'll talk to you now is MDMA-assisted psychotherapy for treating PTSD. It's our number one priority. And one of the things I learned at the Kennedy School was strategy. And so MDMA is the most gentle of all the psychedelics. And so it's going to be easier for the field of psychiatry and psychotherapy, psychology to work with MDMA. And it's ideal for treating PTSD. And PTSD is a really ideal patient population because it's well known that the currently available medicines and therapies work for some, but leave a large number of people treatment resistant. There's over 1,039,000 veterans on disability for PTSD, costing the VA about $17 billion a year. And the people with PTSD, although the veterans get a lot of the attention, it's roughly 2/3 women in our studies, from sexual abuse, domestic violence, rape and assault. And then the rest are men, many of them veterans. But we can work with people with any cause, PTSD from any cause. And these are sympathetic people. So MDMA for PTSD was the strategic choice that I made quite a long time ago. And as it turns out now, we are the sort of the cutting edge of the spear, you could say. We're the only team right now with phase 3 data, that we're in phase 3, the final stage of studies to make MDMA or any psychedelic into a medicine for PTSD. Now, the risk evaluation and mitigation strategies are special rules that the FDA can create to customize to the specific risks of the particular medicine that's been approved. And the reason I'm sharing this right now is to say that our treatment is not MDMA. Our treatment is therapy, that the MDMA helps be more effective. And so the REMS that we've already discussed with the FDA, with the Drug Enforcement Administration, we haven't finalized these, but the key element is that once MDMA becomes a medicine, it's not going to be something that anybody can prescribe. Only people that we've trained can be prescribers, but a lot of the prescribers are just going to be doctors that don't necessarily want to be the therapists. So the only people that are working with the patients are people that we have trained, either directly through MAPS or through collaborations that we have with the University of Baltimore and with other groups where we've sort of trained the teachers about what our key elements of our therapist training program are. And so eventually we hope that schools of psychiatry, schools of psychotherapy will adopt this. But right now, the University of Baltimore is in position to be one of the leading institutions that we try to work with to train people. And it's only administered in certified clinics. What we mean by that is that it's only going to be prescribed under direct supervision of the therapist. It's never going to be a take-home medicine. So you can see that the key limiting factor to scaling to the number of people that need it, there's roughly 8 million people in the US with PTSD, is going to be our ability to train therapists. And that's why we're so excited to be presenting to you tonight about ways to work with you to train more therapists. Now, we're struggling with the FDA about the qualifications for the therapy team. We made agreements with FDA back in 2018 about how we proceed. And they said that for our therapy, the licensed, it's a 2-person therapy team for each individual. We've not done group therapy yet. So of the 2-person team, we like it usually to be male, female. People often get regressed into childhood states, childhood trauma, but the lead person just needs to be a licensed therapist and they need our training. And the second person needs to be a bachelor's degree, which we are going to argue against later. We don't think that's necessary. They need to be either licensed to perform therapy or pursuing licensure or have 1,000 hours of mental health work experience, and they have our training. But afterwards, when psilocybin groups from Compass and Usona, 2 different companies, came, the FDA started worrying about their own reputations, you could say. And so they started saying that the lead therapist needs to be an MD or a PhD with training for the sponsor, and the second person needs to be just a bachelor's degree with training from the sponsor. So it doesn't make any sense at all for the lead person to be an MD, PhD. And we had a meeting with FDA to argue against this, and they'll tell us at the end of April. But I think they're going to give up with this MD, PhD. So what that means is that the lead person will just need to be licensed to do a therapy of any kind. Could it be clinical social workers? Could be anybody with a license. And then the thought that MDs or PhDs, MDs, even psychiatrists, aren't even trained to do therapy. So the idea that they would somehow be more effective therapists is, the FDA just thought these credentials look like we're being hard on these people, but it didn't make sense. So what we're anticipating is that they'll get rid of the MD, PhD, which would really open it up to more people to be trained and to provide the therapy. Now, we've been very ineffective, I would say, in recruiting patients of color into our studies. In our phase 2 studies, it really was very disappointing. And so we realized that what we really needed to do was train therapists of color and sort of build trust that way to get more patients of color. So we did do this special training for therapists of color, and that was really effective, and we want to expand that. The phase 2 data that we gathered, so I mentioned that we started MAPS in 1986. So it took us 30 years to get the phase 2 data to present to FDA in what's called an end of phase 2 meeting. And that was a long time. We had a lot of obstructions from the FDA initially, then funding was a challenge, but we eventually did it. And when we presented this data to the FDA, November 29th, 2016, it was from 6 studies from Israel, Canada, Switzerland, and the United States, 105 people. We tested all sorts of different active doses and comparator doses. And what we looked at was trying to figure out what are the most effective doses and what doses could be used for a double blind. And we showed that the most effective doses were 75 to 125 milligrams, in that range. We also, you may have heard about all the concerns about MDMA neurotoxicity and the potential serotonergic neurotoxicity. We don't think it occurs at the doses that we give in therapy, But to double check, we did neuropsychological tests before and after people went through the therapy, and we showed that actually, in most cases, they improved, but they didn't get worse. So there's no concern about this neurotoxicity, and the FDA doesn't even require us to do these measures anymore in phase 3. In the meeting that we had with FDA yesterday, they didn't even say one word about neurotoxicity, but it was used to increase the penalties on MDMA. Right now, if you have a certain amount of MDMA in one hand and you have a certain amount of cocaine in the other hand, and you get caught by the police, you will actually go to jail longer for the MDMA than for the cocaine. So they've managed to scare people a lot about the risks. And so we're hoping one day under the Biden administration, we'll be able to work with the Sentencing Commission and get these things more rational. Now, the results of our phase 2 data were pretty good. Well, we're great. So our therapy control group was people who get therapy with either no MDMA or low dose MDMA, where we were trying for the double blind, but it's a lot of therapy. And we work with the hardest cases, severe, chronic, treatment-resistant PTSD. And unlike a lot of studies with PTSD patients, we include people who've attempted suicide. It's really important not to exclude the most difficult people. And so in our control group, we call it the placebo, but it's really the therapy group, 23% no longer had PTSD at the 2-month follow-up after the last experimental session, which was pretty good for this group. Chronic, severe, on average, treatment-resistant PTSD. But when you add MDMA, 56% no longer have PTSD, more than twice as good. But even more important is the 12-month follow-up. So at the 2-month follow-up, that's where we're done. We're not doing any more interventions. People are on their own. They can do whatever they want. If they want to do more therapy or no therapy, so I can't say that the results at 12 months are just due to the MDMA therapy. But what we showed is that 2/3 no longer have PTSD at the 1-year follow-up. People have learned how to process their trauma and their fearful, painful emotions, and they can keep getting better on their own afterwards without the need of more MDMA and without the need of more therapy from us. So this is going to be really good for insurance companies to pay for it, because it's initially more costly than just giving somebody pills or giving them an hour of therapy once every week or two for a long time. So this was very encouraging for us, that the 12-month follow-up. And of the 1/3 that still have PTSD, most of them had clinically significant reductions of PTSD symptoms. If we could have given them a fourth session, maybe they would no longer have PTSD as well. Now, what we learned in phase 2 was, first off, the SSRIs, the medications that are approved for PTSD, Zoloft and Paxil, they worked better in women than in men, and they failed completely in combat-related PTSD. So we did a series of studies, some in women with childhood sexual abuse, others with veterans, firefighters, police officers, and we showed that the cause of PTSD does not matter to our treatment. It works with everybody. So we can enroll people with PTSD from any cause. We did discover that the low doses they did succeed in enhancing the blinding, but they had an anti-therapeutic effect. So what I mean by that is that the people that got the low doses still got better, but they didn't get as much benefit as the people that had therapy with no MDMA. So they felt activated, stimulated. They were there, the patients, to speak and address their trauma, but they didn't have enough of the MDMA to have the fear reduction. So it made them awkward, and many people wanted to drop out. So that meant that in phase 3, we feel that the design, and we persuaded the FDA and the European Medicines Agency to do therapy with no MDMA, therapy with inactive placebo, with therapy with full dose MDMA. We also demonstrated safety, and we also demonstrated medium to large effect sizes. So all of this was really good, and it persuaded the FDA to approve us to phase 3. Now, you'll hear from Matt Johnson soon about the psilocybin research, and what was true with the LSD research in the 1960s and the modern research with psilocybin for the last 20 years is that there's a correlation between the mystical experience, the ego dissolution, and therapeutic outcomes. And we use the same questionnaire, the mystical experience questionnaire that was that's used in the psilocybin research. We also have done LSD research, but we use the same questionnaire, And we showed that a large number of our subjects actually have a full mystical experience according to the questionnaire, but there's no correlation between the mystical experience and therapeutic outcomes. So that's really important for therapists to know. We're not aiming to have somebody have this sort of ego dissolution, unitive experiences. Whatever comes up, we support. Now, based on all this, FDA gave us breakthrough therapy designation. They've since done that for psilocybin for major depressive disorder and also for treatment-resistant depression. And this is our phase 3 design. We have 3 sessions, 8 hours long, with a 2 therapy team. And one group everybody gets screened and enrolled. Then we have 3 of these prep sessions. These are 90 minutes once a week to build the therapeutic alliance, for the therapist to get to know the patients, for the patients to learn about what MDMA is. And then half the group are randomized to get these either inactive placebo once every month, or to get 80 milligrams followed 2 hours later by 40, or most likely 120 followed by 60, or 120 followed by 60. But we give a little flexibility for the patients and the therapist to adjust the dose. And then there's 3 integrative psychotherapy sessions, each 90 minutes after each experimental session. And then there's the 2-month follow-up. So what you can see from this is therapy. And the MDMA makes the therapy more effective, but it's not just here's some MDMA. Now, we agreed with the FDA that we would do 2 100-person phase 3 studies. And that was what was called the special protocol assessment. We came to agreement on that. And we have 15 sites, 2 in Israel, 2 in Canada, and 11 throughout the United States. And so we've been able to complete our first phase 3 study. And we're still trying to get it published. And we just heard from Nature Medicine that they asked us to review and revise and resubmit. And their reviewers' comments were really pretty good. So we think we have a good chance of getting it published in Nature Medicine. But what I can share now is that we had a very small p-value. It was highly statistically significant. We had a large effect size, meaning that not only was it statistically significant, but the drops in the PTSD symptoms were large. We replicated our results from phase 2 and did even slightly better, and we had a very good safety profile. We had 2 people in the study. One person attempted suicide twice, and the other person had such strong suicidal ideation that they checked themselves into a hospital to avoid self-harm. Both of those people were in the control group that got therapy without MDMA. So we had a very good safety profile. And we've now started the second phase 3 study. And we've also are starting what it's called expanded access, compassionate use. And there's going to be a site for compassionate use in Rockville, Maryland, right near the University of Maryland. And so there may be possibilities for therapists going through your training program to be interns or work at this site in Rockville, Maryland for expanded access. We have our own therapeutic method that we've developed. It's up on the MAPS website, and you can read about it. It's based on the work that was done by Stan Groff and others with the LSD research, but we modified it for PTSD and for MDMA. The essence of it, we talk about it as non-directive or inner-directive, meaning that it's not like cognitive behavioral therapy. We support people to go through whatever is emerging, either feelings in their body, thoughts that they have. It's an 8-hour session. People always get around to the trauma, but they may do it in different orders. We believe there's this inner healing intelligence of the psyche. So whatever is coming, we help people support. People are, as you can see in the picture, around half the time they're reclining, listening to headphones with music on eye shades. The other half of the time, they're speaking to the therapists. With psilocybin or LSD, it's more like, and Matt can tell us more about this, but it's more like 80 or 90% of the time, they're listening to music and having this inner experience, and much less verbal and communications with therapists with the classic psychedelics. That's more for the preparation and the integration. We do allow for therapists to innovate, to use some individual variation within limits, and it really stresses the importance of preparation and integration. Now, even though we have this method, we have approached the Veterans Administration and we've said we want to help their therapists learn about MDMA, and we want to fund them to study their methods, blending them with MDMA. And so the first person we did this was Candace Monson, who was head of women's health at the Boston VA. She's now at Ryerson in Toronto. But she developed cognitive behavioral conjoint therapy in dyads, where one member has PTSD, but it affects the relationship. And we bring both people in the dyad into the therapy and both get MDMA. And it's been tremendously effective. We presented to the Boston VA a couple months ago, and Candace showed all the studies with the effect sizes when she was developing cognitive behavioral conjoint therapy without MDMA. And then she showed her results with MDMA, and it was way better with the MDMA. We're also working with Ann Wagner, who's a protege of Candace, on blending MDMA with cognitive processing therapy for PTSD. We're working with Barbara Rothbaum at the Atlanta VA and Emory on blending MDMA with prolonged exposure. And Ed Nafoa, who developed prolonged exposure, is working on us with a study in Israel also to blend MDMA with prolonged exposure. And the reason I'm sharing all this is that I just want to say that while we do have this therapeutic method, MDMA can help all different kinds of therapy. And so it's a tool that can be used in many, many different ways. At the Bronx VA, we've been trying since 1990 to start research inside the VA. So Rachel Yehuda is a renowned researcher with PTSD. She's also done studies in epigenetics. And I think this is also really important for racial trauma, in that she has identified in Holocaust survivors and their children biological markers for how trauma is passed from generation to generation, called epigenetics. And what she's going to do now, and we're just waiting for the approval from DEA. We have FDA approval, IRB approval. We have a signed agreement with the Bronx VA. But she will start a study comparing 2 MDMA sessions versus 3 MDMA sessions. And she will look at these epigenetic markers as well. This would be a historic thing once we are able to have the first person inside the VA receive MDMA. We're also working with the Loma Linda VA, and this is mainly just to train their therapists, but they're also just waiting for this research advisory panel. We think they're maybe 3 weeks away or so, maybe a bit longer from approval. And we're working with Chris Stouffer at the Portland VA on starting to look at group therapy. We think that may be a way to reduce cost and potentially even increase efficacy. We've done studies for MDMA for social anxiety in adults on autistic spectrum. It worked great. We've done studies MDMA for treatment of anxiety associated with life-threatening illness. That also worked well. These have been published, but these are small pilot phase 2 studies. Most of the money and most of the work we're doing is the phase 3 MDMA PTSD. Ben Sessa in England has done this incredible study with MDMA therapy for alcoholism and has gotten good results. And we're about to start a study with MDMA therapy for treating eating disorders. So this is to say it's good for a large number of patient populations and multiple different therapeutic modalities. This is my last slide. And what I want to just share is that our hope is that one day students from the University of Baltimore will be able to work at psychedelic therapy clinics. And the vision that we have is that there's not going to be an MDMA clinic or a psilocybin clinic or a ketamine clinic. It's going to be psychedelic medicine. And so when we think about the training program for your students, we want them to learn about MDMA, psilocybin, and ketamine. And that's why really the new field will be psychedelic medicine. There.
Thank you so much. That was terrific. All right, and I think we did. I might have a few questions, but I think we had a few questions from our attendees as well. Actually, Dr. Eisel, would you like to choose the first question for us?
Sure. One of the questions that
Chris,
I actually had as
Hey, Chris, before you start, I just wanted to welcome, as president of the university, I just wanted to welcome everybody. Thank you all very much. Brother Bob Parsons, of course, is someone that we all have a great feeling for, hold him in high esteem, and thank him for connecting us with Rick. It's great. So I just wanted to butt in for a moment there, and then have the faculty take the lead, as is the true at the whole university. Thanks.
Thank you, Kurt. And we're glad you could join us. So one of the first questions that popped up in the Q&A was one that those of us in psychology departments think about and talk about all the time. And I don't know if anybody can answer this, but do psychedelics help our understanding or help us solve the hard problem of consciousness?
Well, that's a great question. It's a super hard question to answer, of course. And I think the answer is yes, they can. There's actually been some people have been proposing a study of people who are in a coma and whether psychedelics might wake them up in some way. We don't really know if that's the case, but I'm not the right person to really answer. Maybe Matt would know more, because I'm very instrumentally focused on making psychedelics into medicines. And the FDA says, we'd like you to prove safety and efficacy, but you don't have to have mechanism of action data. But I do think that when LSD came out in the 50s, it was instrumental in the discovery of the serotonin system. So the neurotransmitters we know about in part because of LSD, because people were thinking, how could such a tiny molecule, I mean, LSD is in millions of a gram. When you say 250 micrograms, that's 250 millionths of a gram, and yet it fundamentally changes your consciousness. And so people started looking at how could that be? And that's what helped lead to the discovery of the neurotransmitters and serotonin. But that's not quite exactly the question you asked about the mystery of consciousness. How are things conscious? So I am not conscious of the answer to that question.
I don't know that we're going to be solving that tonight, but glad to know that this could be a path in that direction to some of those answers. We had another question from Camilla about what do you think might cause the individual differences in the efficacy of this treatment? Or
Okay, so that we don't know. We had the meeting that we had with the FDA yesterday is they said that that's one of the important questions they would like us to address. How do you predict ahead of time who's going to be a responder and who's not going to be a responder? I mean, these are intensive interventions and you'd like to tailor them to the people that are most likely to get better, but we don't really know. There's been a lot of different theories. First off, in our first phase 2 studies, we thought that people that were higher on the dissociative subtype would take longer to treat. But we found out that in our phase 3 study, those people on the dissociative subtype, which are considered the hardest PTSD patients to treat, actually got better, showed more benefits than the average. For a while, we thought that the longer people tapered off of their SSRI. So I didn't mention this, but we require people to taper off all of their psychiatric medications before they can get in the study, because the SSRIs blunt the effects of MDMA, and we didn't want drug-drug interactions. And it seemed like the more time people have tapered, the better they do. But that data in phase 3 didn't support that. I would say it's this intangible quality of courage. The MDMA helps reduce the fear, but people need to be willing to look at what's painful. And even though the MDMA helps, we've had a lot of our subjects say, I don't know why they call this ecstasy, because it's actually difficult to go through, revisit the trauma, and people are crying, people are shaking. So I think I don't know how we measure this ahead of time, but I do think a courage, a willingness to look at what's difficult is probably the main factor that distinguishes who gets better and who doesn't. Borderline personality, we've had a bunch of borderline personality people sneak into the study, and they get better too, but not as quickly. So I think borderline personality disorder can benefit, but they might need more sessions. So one of the things that we're talking about FDA is called phase 4 commitments, is what you do after the drug is approved as a medicine. And they've said they want us to look at trying to figure out who are responders, who are not responders, and then also to look at relapse rates and how do we treat people who relapse.
Thank you. I don't know how much more time we have. We should probably move on to our next speaker soon. Maybe time for one more question though.
There's a lot of them. So I'm going to pick one from Travis. Would love to hear thoughts about traditional and unsupervised use of psychedelics as a form of intuitive self-medication.
Well, I love that question, particularly with Kurt here, because I believe that these drugs should be legal. But they should be legal in a licensed legalization context where there's honest drug education instead of fear-based drug education, where there is pure drugs that people have access to, where there's harm reduction in place, and also treatment on demand. So traditional, or let's say non-medical, are two different things. So we have the Native American Church that uses peyote. We have the groups that use ayahuasca in South America, the traditional groups that use ibogaine in Africa. And these traditional uses have been thousands of years, and they have refined quite successfully how they use these things for quite a different variety of issues and problems. And so I think the traditional use is really quite well done. The sort of recreational use, you could say, it's more risky than therapeutic use. And I'll just share one story, is that we had 1 week, it was quite over 10 years ago, we had two women approach us in the same week. One said, I went to a rave, I took MDMA, past rape memories came up, and I was with my friends and they didn't want to hear it. They just wanted to have a party. So I stuffed my feelings down, and now it's months later and I'm worse. So I think when people take this, you need to be willing to experience whatever is happening. That same week, another woman said, I went to a rave, I took MDMA, I was with a girlfriend, I remembered having been raped, and we went off into the corner and talked about it for an hour, and I worked through it, and then I went back to the party, and now I feel better, and maybe now MDMA should be good for PTSD. So I think it's the attitude that people bring to it, but that I do think that we need to build a society where fundamental human rights are such that people have the option of trying this. And I think licensed legalization for me means that, alcohol, I don't like the way alcohol is regulated, because you can be a drunk driver, you lose your driver's license, but you still buy alcohol and you kill people without your driver's license. So we should make it harder for them to get alcohol. So I think psychedelics should be like that. You get a license to do it. If you misbehave, you get punished, and you get your license taken away for a while, and you get, educational materials or something like that.
Great, thank you. And I am seeing a lot of other really good questions in the Q&A and also in the chat.
Michael, just to say this, that we can answer them afterwards. I mean, I know there's not time today, but if you send them to me, we can respond afterwards.
Perfect, yeah. So all attendees, be aware, in the Q&A, we can respond to those questions after the event is over as well, if we don't have time to get to them today. Okay, great. We can move on to our second speaker. So Matt Johnson is a professor of psychiatry and behavioral sciences at Johns Hopkins University School of Medicine. Yeah, he's been working with psychedelics since 2004. He's one of the world's most widely published experts on psychedelics. The psychedelic safety guidelines that he published in 2008 helped to resurrect human psychedelic research. Currently, he's the president of the International Society for Research on Psychedelics and associate director at the Center for Psychedelic and Consciousness Research at Johns Hopkins. We're very grateful for his participation today and excited about the potential for future collaborations right here in the Baltimore area. And so with that, I will turn things over to Matt Johnson.
Very cool. Well, I'd like to really thank you, Mike, for setting this thing up, and your fellow faculty members at the University of Baltimore. And special thanks to Rick for roping me into this great group. I've really enjoyed this evening so far, starting out with those wonderful personal reflections from Bob. So I'm going to go ahead and share my screen and shift a little bit and talk a little more about psilocybin, shift compounds here. So let's see. Share. Okay. Folks seeing me now? Showing up good? All right, beautiful. All right, as I said, we're jumping molecules here and moving on to psilocybin. First, just by way of disclosure, just I advise several companies developing psychedelics or related compounds through the FDA pathway that I'm showing you there. So psilocybin, most folks hopefully know that it's the active agent in so-called magic mushrooms, over 200 species of mushrooms. So it's a classic psychedelic, and that makes it different than MDMA. Classic psychedelic, that puts it in the same class as LSD, or mescaline, which is in peyote, dimethyltryptamine, which is in ayahuasca. So MDMA works by releasing serotonin compounds. These classic psychedelics work by activating a subtype of serotonin receptor called the serotonin 2A receptor. So different pharmacology, and that's largely responsible for the differences in their effects. And absolutely historic and prehistoric history of use of psilocybin containing mushrooms. I'm showing you on the left and on the center depictions from Mesoamerica and South America dating back from several hundreds to a couple of thousand years ago, suggesting sacramental use of these mushrooms. But the most ancient, I'm showing you on the right, from cave paintings in Northern Africa, dating back to around 9,000 years ago. So that's several thousand years before the first human civilizations in Mesopotamia. So this stuff goes back, it's truly ancient. If you buy, and I think there's a good case to be made that all of these are depicting some type of ecstatic sacramental use of these mushrooms. So fast forwarding through some millennia, we get through the 1940s to the 70s, sort of the heyday, the classic era of psychedelic research. They were intensively investigated, both as basic tools to understand the mind, to understand the nature, for example, of schizophrenia. That was one of the things looked at, but also as therapeutics. And so the most promising therapeutic findings for these classic psychedelics, and this was largely done with LSD, was helping people with cancer-related distress, people with terminal cancer who were really suffering from the existential distress associated with having that dying soon, and also in the treatment of alcoholism. And then, of course, we entered the dark ages. Right when things were getting going and looking promising, the rug was pulled out from underneath the researchers. And so there was a decades-long dormancy. And an important point to make is that this dormancy happened, for one, yes, there were casualties, especially in the very late 60s and early 70s, as the street use of LSD really ramped up. There were certainly casualties, but it was really more so that combined with the sensationalism by the media that failed to distinguish the most reckless use of these compounds from some of the very responsible use that was going on in clinical research. And there was a lot going on in clinical research, and you can point to examples that were less than responsible, but there was quite a number of folks that were doing very good. They were well aware of potential risks, and they were very mindful of them and doing very good work. So then, Rick showed very similar chart from a different database, but same kind of theme here. So I'm looking at PubMed, the Index of Scientific Publications, looking to instances in which psychedelic or hallucinogen show up in the title of a paper, and going all the way back to 1980 here, and showing just a steady baseline for about 20 years until you see this uptick in the early 2000s. And that was when I was lucky to get started in 2004 in psychedelic research. And we've just seen this exponential increase in interest in this area since. And I don't think that's going to stop. I won't go into details, but just to let you know, of course, as with MDMA, with these classic psychedelics like psilocybin, there are risks. We know, important thing is we know a lot about what those risks are. And in the context of therapeutic work, the question is, what are the mitigation strategies? What do we have in place to squarely address those risks and bring those risks down to an acceptable level? And I would argue, both for MDMA and for psilocybin, that with the safeguards that were in place with these clinical research trials, these compare very favorably to a whole lot of what we see going on in medicine. Nothing is without risks, but these have a very, I think, remarkably strong safety profile. And I'll refer you to some publications that I've helped with over the years that have reviewed that, including one in 2018, where we specifically addressed what Rick had mentioned, the risk evaluation mitigation strategies, the REMS. What would a REMS look like for psilocybin if it were to approved? And I think it will be, if and when it will be approved as a medicine. And how should it be scheduled? And we argue that it should not be overscheduled. If psilocybin is still in the Controlled Substances Act, it Schedule 4 would make sense, but with additional restrictions, such as Rick said with MDMA, that this is done in the clinic with licensed therapists. So much of what I'm going to tell you is really all based on this clinical model. As Rick mentioned, with psilocybin, spend a little more time going inside rather than talking. We want to encourage people to spend as much time as possible just introspecting. So this is a mock participant. They're lying on a couch for most of these 6 hours. 80 to 90% of the time is spent with the person. It's actually often pretty boring to watch, in fact, you kind of want it to be boring, where the interesting stuff is told to you afterwards. And if they're not having very difficult material, it's smooth sailing. They're just kind of going inward. So they're wearing eye masks, they're wearing headphones through which a music program is played, and you're there for support. And one of the most powerful things you can do, and you prepare them for this, is just you hold their hand when they're having strong anxiety and let them know you're with them. And this is only with people, the guides have built a clinical relationship with them, anywhere from 4 to 8 hours across our different studies. So it's someone that they've learned to trust, and they have that rapport with them. And I've served that role in over 100 sessions, so I know well what it feels like to be in that position where, these, especially with psilocybin, the challenging experiences can be quite extreme, and it really is that interpersonal grounding that is the most powerful tool to mitigate that. So I'll give a bird's eye view from a number of our findings, just quickly to summarize some of our healthy normal studies. In other words, studies where we're not nominally treating a nominal disorder, we're just examining its effects under optimal conditions. But conducted a couple of studies with high dose psilocybin. In combining those two studies, we found something very interesting. We found that psilocybin resulted in an increase in the personality domain called openness to experience. And what that personality domain refers to is a tolerance for other people's points of views, the ability to hold seemingly mutually exclusive notions at the same time, to think more of an both and rather than an either or framework, and an appreciation for aesthetics. And so this is remarkable, because this is the first time to our knowledge that any relatively discrete clinical or laboratory intervention has actually changed a personality construct. That's the definition of personality, right? It's a trait. It's not supposed to change. We know some things like, over the decades, as you get old, certain things change, like openness, in fact, decreases. So a little bit of a fountain of youth effect here, because we were going in the opposite direction with psilocybin. But by and large, major life events can have some effect, but nothing that you can kind of plan for next Tuesday is going to change personality. And now this has been replicated with other psychedelics and in other labs. And we found that it wasn't just getting psilocybin, it was actually having this mystical experience that Rick referred to, having this sense of unity, feeling like you've transcended the bounds of time and space, an ineffable aspect to it. When the person says, no matter how hard I try, this was beyond words fundamentally. Those types of domains, that's the mystical experience. And for the people that had the same high dose of psilocybin, for those who had, as rated at the end of their session day, a mystical experience, we saw that long-term change and increase in personality openness. And for those people that had that same dose and didn't have that type of subjective effect, at least to that degree, we didn't see that, not even a trend. And so you'll see time and time again, I'll show you some data consistent with that in our therapeutic studies. It's not just getting the psilocybin, it is the nature of the experience that unfolds that seems to be related to its ability to heal people psychologically and cause a change long term. So I've already mentioned this, but I think it's worth saying the mystical experience, it might sound woo-woo, but it's a validated psychological construct. It's nominally distinct from any supernatural belief. So you can be an honest atheist and completely endorse a mystical experience. So it involves those factors that I already mentioned. And I think there's probably a whole lot underneath the hood. We need to continue to do research, and I'm imagining that this is more kind of a basic psychological constructs and biological processes that underlie this. But right now it's a really good proxy for one of the things that seems to be associated with psilocybin for positive therapeutic effects. And that appears to be the case for LSD as well, the classic psychedelics. So shifting into our the first therapeutic study I'll show you, this is picking up on that older LSD work with terminal cancer patients. So we worked with here in Baltimore, 51 cancer patients, all had life-threatening cancer, not necessarily terminal, although some were certainly terminal. About a third had a DSM disorder associated with depressive symptoms, about a third associated with anxiety symptoms, about a third had a mixture of both. Very quickly with the design, everyone had either the real deal high dose of psilocybin in one session, and they had a trivial dose or low dose in the other session. So that trivial low dose was really meant to serve basically the function of a placebo. We could tell people honestly that you're getting psilocybin in both sessions and the dose is going to vary. And we did guarantee it would be, one of them would be moderately high at least, but they thought they could have 2 high dose sessions. So they were kind of kept on their toes in terms of what to expect, but they either had high dose first, trivial dose trivial dose afterwards 5 weeks later, or vice versa. Okay. So we assess symptoms before we cross people over to that other condition. And so we have follow-up data after each session, 5 weeks after. And then finally we had a 6-month follow-up time point. So I'm just showing you 2 of our measures out of many measures, but this is our gold standard depression scale, the Hamilton Depression Inventory and Hamilton Anxiety Inventories. People are coming in at baseline for both depression and anxiety. Trust me, these are very clinically severe levels. And both of the randomized groups are showing up at very high levels. And it makes sense they're at the same level at that point. Nothing has differed between them at this point. In fact, they haven't been randomized yet. Then you'll see post 1 is 5 weeks after the first psilocybin session. The people in red have gotten the real deal at that point. And you see a dramatic reduction on average into the range of the scale, suggesting on average, you're not suffering from a clinical disorder. I mean, this is the normal range of the scale. This is where you want to be. Very few people are at 0. The low dose group also sees a very sizable reduction. And I think that's likely due to 1, 8 hours of preparation, really talking about your life, talking about your cancer, that rapport building. That's not to be dismissed. But above and beyond that, just the plain old, what we call the placebo effect, expectancy. It was a low dose. People could feel a little bit. So some people may have thought they got the real deal. Nonetheless, those reductions were nowhere close to what they were with the high dose. And they were statistically distinguishable from each other. However, 5 weeks after the crossover, now everyone has gotten the real deal dose at post 2 on the x-axis, whether it was 5 weeks ago or 10 weeks ago. And now both groups on average are down to that same very low level of symptoms. And so it's remarkable enough to have one administration of a medication, and for a psychiatric, issue, for one administration of a med to have effects 5 weeks afterwards, right? That's unheard of. It's even more astonishing that the results were virtually unchanged 6 months later. And you see that for that basic pattern for depression and anxiety. And I'll say our colleagues at NYU had a follow-up study over 4 years later and found largely the same thing. So following with that theme of mystical experience, we found that the degree of reduction in depression and anxiety long-term was significantly correlated to the degree of mystical experience as measured on their session day, even above and beyond controlling for just that person's rating of how strong the drug was, ratings of drug intensity, drug strength. So it's not just getting hit over the head with a strong drug effect. There's something about that particular psychological experience, the sense of unity, et cetera, in the mystical experience. And won't go into details, but to say we published these results at the same time as our colleagues at New York University. They had a slightly different design, had niacin as the active placebo. Nonetheless, also extremely large effect sizes like us, virtually identical results. So very robust in terms of like finding the same results with a different method and different design. So stepping outside of cancer, our colleagues at Imperial College London published this study back in 2016. So major depressive disorder, again, not cancer patients, but this was an open label, a first stab at this, single group, no randomization, but found long-term up to 3-month reductions in depressive symptoms. We recently, just a couple of months ago, published in JAMA Psychiatry the first randomized study using psilocybin to treat depressive symptoms. This was a randomized wait list control study. In other words, people were randomized to receive, after the preparation sessions, either more immediately 2 psilocybin sessions, open label, right away, or to wait about a month later to have their psilocybin sessions. And so what you're seeing in the results that I'm showing you here is that people had similar depression scores at baseline. After that, at week 5, the people who have now received those 2 psilocybin sessions, you see dramatic reductions in depression and no change in the group that's just waiting. And the same thing at week 8. And although I'm not showing it here, eventually the folks in the delayed treatment group were crossed over and received those 2 sessions, and their scores plummeted down to the nearly identical level as those people that got the psilocybin immediately. So I'll shift into addiction treatment here. So this is based on that older work I mentioned for LSD and alcoholism. It was often called a mixed bag, some statistically significant responses, some not, but some Norwegian colleagues almost a decade ago now did a meta-analysis. There were only 6 trials that actually randomized people to either LSD or some other condition. And so they took only those trials and ran them through a meta-analysis, which is basically a way to get different studies that use different methods and different stats to talk the same statistical language, to compare their results, to group the results together. And what they found basically that there was a trend for every single one of the studies, whether it was statistically significant when they originally published or not, there was a trend for every study for LSD to do better. So anything that shows up to the right of that vertical line in the middle favors LSD. But in aggregate, the big fat diamond at the bottom, that's the aggregate data across the 6 studies, showed a very large effect. So it was not only statistically significant, but more importantly, a large effect. In this case, meaning the odds ratio of about 2, which basically means that at that first follow-up, the people who received LSD, that it nearly doubled the odds that they were improved at that first outcome compared to the control conditions. So I moved into smoking cessation. There's already this cross drug addiction, sort of anti-addiction potential. There was one really promising report from, again, here in Baltimore back in the early 70s in treating heroin addiction. There's anecdotes, you name it, out there for overcoming any drug addiction with psychedelics. So I thought, okay, let's try cigarette smoking. And there had been a few anecdotes out there with that at the time. In fact, Leo Zeff, the famed underground psychedelic therapist, reported in his in the book The Secret Chief, published by MAPS, that he had stopped smoking during a psychedelic therapy session, and even though it wasn't his intent to stop smoking because of that session. So we gave it a stab. It was a feasibility study, didn't have much money, so, and we also wanted to test the water, so it was a single group, basically 15 people. They were a pack a day smokers on average. They'd been smoking 30 years on average. These were not lightweights. It was a 15-week protocol. We combined it with cognitive behavioral therapy. So that's sort of the bread and butter standard type of talk therapy you do to help someone quit smoking. things like keeping a smoking diary, assigning a target quit date before you quit rather than just quitting on the fly. And while you continue to smoke, when you until that time, you write down when you smoke, kind of your thoughts and your feelings, kind of what situation is occurring. You prepare them what to do. If you do slip and have a cigarette, how do you handle that? Do you dwell in guilt, or do you kind of treat it as a learning experience, which research shows is more likely to lead to success? So all of these types of things, that's the cognitive behavioral therapy, not done during the psilocybin sessions, but in those preparation sessions and in follow-up sessions. There were 3 psilocybin sessions ranging from a moderate to high dose over an 8-week period. And that first psilocybin session was the same day that they were going to quit smoking. So this is a big day. Imagine this, like you're going to quit smoking, you've been smoking 30 years and now you're going to quit today. And you're also going to get hit with a big psilocybin session. This is one of our 2 biological metrics of whether you've been recently smoking or not. I call it trust, but verify. So this is carbon monoxide. It's like a breathalyzer, but for smoking. This is before they had the psilocybin for a psilocybin session. This is after. You don't have to be a stats whiz to see you have a pre-post difference. Another way to look at the data is point prevalence abstinence. In other words, at each time point, what percentage of participants are abstinent at that time. So at 6 months, 80% were biologically verified abstinent. That held up to, on average, of 2.5 years to 60%, which is very large. Again, the mystical experience on their session day was correlated with treatment success. That paved the way for what we're doing currently. We're mostly through a randomized comparative efficacy trial where we're taking 80 treatment-resistant smokers, randomizing 1 psilocybin session or nicotine patch using the standard FDA label methods for nicotine patch. The same cognitive behavioral therapy in the other sessions. Results could change, but for the 44 people who have gotten to their 1-year follow-up, as the results are right now, 59% of the people in the psilocybin group are biologically confirmed as abstinent compared to 27% in the nicotine patch group. And I'll tell you, that is very, very good for nicotine patch. That is well above average. So I'm proud we're doing a good job even in that group. But 59%, again, it could change, but these are, much larger than what's ever been reported in the literature. But again, it could change. But I will note one thing on this that, Rick's slides made me think of. I think psychedelic therapy is one of the few things, certainly the only medication, the medication component of it, where you actually see the therapy getting better over time. It's very rare. I don't know of cases where point prevalence abstinence rates increase the longer you get away from the treatment. Usually you see it going in the other direction. You see a survival curve. So something is interesting here. It's people learn something. They change the way, some people do slip and they fall back for a while, and then they learn. There are some deep lessons. So that's one way to state it. So I think we have a whole lot to figure out there. A very similar line of research has been conducted by our colleague Michael Bogenschutz, now at New York University, published a very similar pilot study showing large reductions in drinking days in folks with alcohol use disorder. He's recently completed a 100-person randomized clinical trial with psilocybin for alcohol use disorder. So we're still waiting those results. With my colleagues, have published several studies in the literature just documenting these stories of people saying they had an addiction to one substance or another, and they tried a psychedelic, usually just for fun or for exploration, not to quit, not anything to do with their substance use. And, they report either stopping or drastically reducing that substance. So we've reported that for tobacco, for alcohol, for opioids, for cocaine, methamphetamine, cannabis, you name it, there's stories out there. So, as sort of a compliment and perhaps pointing us in future directions. So kind of big picture, what are the common mechanisms here? Like, is this stuff working for it? It's either working for all of these different things. And again, we've got to follow the data, but if it holds up, it's either working for everything. And that should make you suspicious of snake oil, or there are some common mechanisms at play. And that's where we should be looking. And the way I think about those common mechanisms is everything I've described involves addiction broadly defined, whether it's to a substance or a way of thinking about yourself in the form of depression, or how you're dealing with cancer, life is just punishing me. I'm never going to make it, like, or in depression. I'm never, I'm just a failure. There's never any hope. There's addiction going on. Which is a way of saying people are stuck. And people seem to be able to get unstuck with this treatment. It's a dramatic experience that can unstick people. And one way to put that, Michael Pollan credited me with the very unscientific name of the dope slap effect in his book. But basically the idea is people are dope slapped out of their story. A window of mental flexibility is opened up where people can let go of those models that they organize reality, whether it's I'm just a cigarette smoker, I'm never going to be able to quit, or I'm just a failure, no one likes me, as in depression. People can let go of those things somehow, and it can be compelling for them. So future directions, we've told you about MDMA and psilocybin. There's been a bit in the modern era with LSD, but we need to look at different compounds. I've recently gotten funding to look at LSD treatment for chronic pain. So looking forward to that, but there's hopefully, we know that there's dozens and dozens of compounds out there that Sasha Shulgin, Dave Nichols, and others have created that need to be explored, and ones that have yet to be synthesized yet. Different disorders involving narrow behavioral repertoire. I mean, you can just go through the DSM, the Psychiatric Bible, and there's a good chunk of them that need to be tested with psychedelic therapy. We need more experimental work on expanding psychedelic therapy. Rick mentioned this. It's like, you named the empirically validated form of psychotherapy. We need to look at that under the lens of the different psychedelics. For these combinations, we might be able to get much better mileage than even we're seeing in some of the current trials. And and we need to expand how do some experimental work on how psychedelic therapy is conducted. And so despite 80 years, we really are sticking to this model with the classic psychedelics of, with the eye shades, with the music, with the introspective framework. Seems to work really good, but we don't have much experimentation around it. Our group just recently published a little bit of experimentation surrounding the form of psychedelic therapy, in the sense of randomizing what music people are listening to. The most typical thing has been classical music that goes all the way back to the beginning of psychedelic therapy. We developed an alternative playlist with sort of a harmonic, overtone-rich instruments like didgeridoo and gong, and actually found slightly better results, both in terms of smoking cessation and in terms of mystical experience with this alternative playlist. They were about the same, but I think it was a clear demonstration that, hey, you can deviate from the standard and not be freaked out that, like, psychedelic therapy is so fragile, we can't change up the music without the thing falling apart. So, we were calling for more exploration like this. What if we, modify other aspects of the therapeutic treatment? What if more of it occurred in nature, for example? I mean, you could just come up with dozens of examples. Understanding psychedelic action from a basic learning perspective, both behaviorally and biologically. I think, since I'm a behaviorist, these are learning experiences, and we need to do a lot more to understand that from a basic learning perspective. And understanding integration, which basically just means discussion of the experience, but we also have people write a narrative the night of their session. But we really don't, there's this concept that there's an afterglow after these sessions that last a few days or weeks. We don't know really what that is scientifically. How long does it typically last? Is that an opening? Is there more mental flexibility? I think that's a good chance during that period. And can we leverage that in a more systematic way? What can we do? Maybe we need to do things more on a daily basis during whatever afterglow period there is. So there's a whole lot of science that needs to be done there. Finally, I think there's a whole lot of, work in ethics as these treatments are rolled out with challenges. These are big experiences, and people often hold them from in a spiritual framework, sometimes involving religious or more supernatural frameworks, sometimes more humanistic or secular frameworks. But that's something that's going to pose a challenge for the field. And so I recently wrote a commentary on this: consciousness, religion, and gurus, pitfalls of psychedelic medicine, really kind of providing some advice and some critique about how things are done, how we should really have a more open framework, kind of have a less of a new agey vibe to these sessions, to kind of have a more welcoming, whether, someone's coming from the lack of a religious tradition, or from say someone's a Muslim and they don't like the fact that you've loaded the room with a Buddha statue and this type of thing. You need to be very thoughtful. And also, how is this going to roll out into VAs? Is it going to be picked up by Medicare, insurance companies to provide coverage? So, and taking a light hand in terms of metaphysical, people get into metaphysical territory with this stuff. I think it's critical that we let the client, the participant, the patient guide the way there, and not impose our own framework onto that, whatever that is. And to just, let the client lead the way with that. And finally, as I also alluded to in that commentary, a whole lot of work we need to do on consciousness. And in fact, I wrote a little bit about this, the hard problem of consciousness that came up, and concluded that's going to be a tough one, because it's the hard problem. And for those that aren't familiar, this is essentially explaining the existence of phenomenal consciousness. In other words, why there is any experience at all, or as Nagel described, what it is like to be something. What is it like to be a bat? Presumably it is like something to be that animal. Why is there some experience there rather than not? And seemingly there's no level of objective science that could ever address that question. Can psychedelics address that? I don't know of anyone who can think of a conceivable way where they can at this point. But in the paper, I encourage, we should try. We should be open and try. But other things that are called consciousness, and we need to do a better job using the term consciousness, other concepts that we call consciousness, such as the sense of agency, or the sense of self, or conscious access. In other words, like what you're aware of at this moment versus another moment when you're prompted to think of something. Those types of consciousness, if you will, we can figure out a whole lot by using psychedelics as tools. And I think we're in our infancy, and we really need to dig into that a lot more. And just need to do a lot of thinking about how we can mainstream these as treatments, because hopefully we're going to be within a few years of the first clinical approvals, and need these to help as many people as possible in society that we can. So with that, just want to thank a whole lot of folks. I've shown you a bird's eye view of a whole lot of work. So I'm surely I've forgotten a bunch of people, even despite the large number of people on this slide, but certainly the biggies being Roland Griffiths, Mary Cosmano, Al Garcia, Fred Barrett. So you can check out our website at hopkinspsychedelic.org. And that's it for me. Unless
Great.
There's any questions.
Thank you so much, Matt. It's very, very impressive work. We have time for probably just one or two quick questions. So Stephanie had a question that I think maybe some people would be wondering about. She asked, are the sessions guided? For example, are patients in the smoking cessation group guided to explore thoughts regarding smoking or quitting smoking?
That's a great question. Basically, the answer is no, they're not. In fact, it's been said before, guide is probably a misnomer with this type of approach. So it's non-directive, and particularly for psilocybin, the guides are just there to put out the fires. In other words, if the person starts having some strong anxiety, some nervousness, or they just, sometimes doesn't matter what they're supposed to, do, they sit up and they need to talk about something, and you're there for them. You provide that reassurance and that grounding. But, they're on their own. And the instructions that we give them for smoking cessation is, and I can truthfully tell people this, we've had participants that think about smoking a lot during the session, and we've had people that didn't think about it all day long. And I can, there's examples of both types of those folks that have successfully quit smoking with this, and that believe that psilocybin was critical to that. So we're still figuring out how it works, but I do not think that it relies on this instruction to, really focus on smoking. And the reason I think that wouldn't be the right approach is that, this goes back to the heart of what everyone has said about this, Groff and and others going back to the 1960s and 50s. It's like the folks that really figure it out, like if you're getting the dose high enough, like we're dealing with, these are high doses. You can't, if you're trying to control the experience, you're not going to get the fullest out of it. You have to completely psychologically surrender to the experience. You cannot force it. You can put out a wish, show me something about smoking, but prepare the person, hey, it may not come back. It might be the message in the bottle that you throw out and it never comes back. But you know what? It can come back the day after your session or a week later. And oftentimes that happens. Like, not all of the magic happens on the session. Like, this really puts you in a different place. And just because the major drug effects are over doesn't mean the process is over. So put out the intentions, put out the questions, but take that light hand of just go wherever it leads you and surrender to it.
I'd like to jump in one more time and just say that there have been a lot of questions about the spiritual experience, the mystical experience, and that might best come after Joseph speaks. The other question that I see popping up all over the place is that have there been any comparative studies? So how does the effectiveness of MDMA line up with the effectiveness of psilocybin, line up with the effectiveness of other psychedelic compounds?
There have been no studies, and oh boy, am I looking forward to that work. One of the cool things that we're going to be starting, we have the funding and I have the protocols in process, but we're going to be looking at psilocybin and treatment of PTSD. And so I'm extremely hopeful for that. If that ends up looking promising, then obviously down the road, hey, we need to do MDMA, compare MDMA to psilocybin, but it's not all, comparison either. It's like, if psilocybin looks promising, then we need to get into the world of, hey, maybe the best formula is you have a session with MDMA, and then depending on your experience with that, then you move on to psilocybin. And this is what Leo Zeff and other underground therapists have done for decades. So we've just got so much fun work ahead of us. But basically, no, there hasn't been any of that type of comparison yet.
Thank you. All right, and our third speaker this evening, Joseph McCullen, is a licensed clinical psychologist and psychotherapist who received his doctorate in clinical psychology from the Chicago School of Professional Psychology. He currently works in Los Angeles as a co-therapist on the phase 3 clinical trials sponsored by MAPS for MDMA-assisted psychotherapy for PTSD. He's also an alum of MAPS' first MDMA therapy training for communities of color held in August 2019. And additionally, Joseph works as a clinical supervisor and training coordinator at the nonprofit St. Joseph Center in Venice, California, which provides mental health support to low-income and unhoused individuals and families. He's deeply passionate about furthering education and awareness of the healing benefits of psychedelics for communities of color and working to improve mental health outcomes for historically underserved communities. It is my pleasure to welcome Joseph McCullen.
Thank you. Thank you, Michael. I'm grateful to you and members of faculty at the University of Baltimore. Thank you for Bob Parsons for that amazing, beautiful story. And it's an absolute honor to be sharing this virtual stage with these two amazing giants in the field, Rick Doblin and Matthew Johnson. And it's truly humbling. Through this, I'll be doing a little bit less screen sharing and a little bit more story sharing here and there, but hope you can all connect with this. I'm from California, in California now, more specifically Los Angeles, and we're all arriving here to this space from our various cities across the country, and we all come with a story and tons of wisdom about ourselves and our experiences. And what I've realized over the years as a therapist, discovering and making meaning of our own personal story, our ancestral story, and our collective story allows us to deepen our capacity to see the complexity of the story in everyone we work with. So I'm going to begin by sharing a piece of me and my story. And I have, just to support this, I'm actually going to share a visual. This isn't a mistake. You should be seeing like a freeway. Okay. And this is a recent aerial photo of the Santa Monica Freeway in Los Angeles. And I grew up in Santa Monica, which is a beautiful city. It's on the west side of Los Angeles, and it's right next to the Pacific Ocean. And it's not far from where I currently live now. Santa Monica was diverse racially, but also very racially segregated. And my hometown had both pockets of wealth as well as pockets of poverty. And if you've ever been to LA, you can't miss either flying in or driving in the vast network of interconnected freeways. And the house I grew up in sat right next to this freeway running through the city from east to west, like a little bit to the left of this interchange. And the Santa Monica Freeway divides the city along racial and economic lines. And it essentially is the city's equator. It marks the line between the wider and wealthier neighborhoods to the north and the neighborhoods of less resources and more people of color to the south. During its construction in the 60s, the freeway displaced a large segment of the city's Black and brown communities, essentially carrying the intergenerational torch of colonization and systemic racism through the city's most diverse neighborhoods. Growing up Black next to the freeway in Santa Monica meant existing and living on the boundary between races and resources in the city, and it brought me into daily contact with two very different worlds. Every day I was bouncing between the worlds of the haves and the have-nots. Every day I traveled across town to attend schools in the white neighborhoods because my older brother, Justin, who had Down syndrome, could not get the care and support he needed in our neighborhood. The schools in our neighborhood were too underfunded and under-resourced to support my brother, a student with unique abilities and special needs. I'll never know how my life would have been different if I hadn't attended the all-white schools with the money and the resources. But I do know that if we had the resources that we needed in our neighborhood, quality care and education would have been easier to come by for my brother and our family. I recognize the freeway as part of my story, my family's story, and the history of my city. It has gotten me to reflect on our collective story, the history of our country, and the current challenges facing people of color. The freeway is a reminder of what still divides us, as well as what connects us and brings us together. The way it scars the LA landscape reveals the history of harms for people of color by the structures and systems we've created, and it clearly marks where wealth, power, privilege, and resources are held and where they're not. My family story tells the story of many people of color across our country who, like my brother, have unique needs and need special care, but they encounter obstacles to accessing that care. They don't know about that care, or they can't find that care in their own community. So this is a little bit of my story, and you might be wondering, like, what does this have to do with psychedelics? But I grew up moving through two different worlds, and my hometown was divided when it came to resources and access. And when it comes to people accessing psychedelic therapy and participating in psychedelic research, for white people and people of color, there are still very much two very different worlds. So let's look at where we are now. And psychedelics are emerging into the collective consciousness and poised to become accessible treatments in the years to come. And certainly Matt and Rick, these two legends, have so much to do with that, and beyond grateful to them both and the work of so many others who've gotten us here and keep the momentum going every day. We see decriminalization support in cities across the country. These are all really huge developments, and it's likely more states and cities are going to follow in the years to come, and research continues to trend toward showing safety and efficacy in treating a variety of conditions, from treatment-resistant depression to PTSD to drug addiction. And we've seen the FDA provide breakthrough designation status to both MDMA and psilocybin. So things are trending in the right direction, but what we also notice is the current trend of predominantly white folks who are aware of and accessing these treatments, and people of color who are largely wary, unaware, or both. And it's no surprise this is where we are, and this makes sense if we consider our history. When we consider psychedelic psychotherapy research, and we look at what that carries with it historically, people of color are facing what I call the triple stigma or the triple threat. You really have a trifecta when it comes to stigma here. It's research, psychedelics, and therapy are all highly stigmatized for people of color. In fact, the stigma and fear around psychedelics is enormous. It's the reality is, the war on drugs was did not just reclassify or classify psychedelics under Schedule 1, but people of color were the #1 target in that war. And due to a history of harms in healthcare and research settings for generations, people of color have current fears around being researched, studied, or treated in a mental health or healthcare setting. So it's important to start from the place of realizing all of this makes sense, and we really shouldn't be surprised. It can almost be a mantra when we reflect on the challenges with including diverse populations in psychedelic research. In essence, we just need to repeat that it makes sense. It makes sense. People of color are not lining up for these studies and treatments. It makes sense. People of color are afraid. It makes sense. There are not many therapists of color in this field or doing this work. And if we really think about it, all of this makes sense. But what also makes sense is that we need to do more, and we need to be more intentional about what we're doing, and that it makes sense that we have a lot of work to do, and that this work is going to be long-term work. But the work going forward with working with more people of color and more diverse populations will involve deepening our understanding of the unique challenges people of color are facing and becoming more prepared, trained, and equipped to work with them. The reality is the field currently isn't fully prepared to work with people of color because we haven't. People of color have rarely been participants in the studies and have rarely been amongst the ranks of researchers or therapists in the studies. And as a result, their voices have not been heard when it comes to developing approaches to treatment and care. For therapists and researchers of color out there interested in coming into this work, your work and your voice is needed. And there's a lot of work to do, so be ready, and we need you. And people of color have unique needs. And if the field is going to make the necessary shift to working with more diverse clients and participants, as a field, we need to expand our conceptualization of trauma, and along with PTSD, learning more through research and science about other types of trauma, and develop research that really explores the effects of race-based stress and trauma, and learning to work with psychedelics with people of color, with racial trauma and intergenerational trauma. Therapists will need to undergo new learning and training to become equipped with the tools to support a client or participant who has racial trauma or intergenerational trauma. And for some, these may be new terms, but they're part of the everyday experience for Black folks and people of color across the country. I'm going to share just like a brief story to help y'all understand intergenerational trauma and what that means for me and many people. I remember first really understanding what this was as a young kid, and I didn't know it by that name, but it was when I developed an understanding of how the trauma experienced by my ancestors is carried in me and other Black people today. Like I mentioned, I'm from California, and out here, we're blessed with beautiful outdoor spaces and parks. And my family would go camping in the same place in Yosemite National Park every year. When I was about 10 years old, after a few years of just going, and every single person I would see was white, I asked my dad, why are we always the only Black people here? And his response was, where my family's from, in the South, Black people don't go camping. They don't go into the mountains, they don't go into the woods, they're too scared. They'll end up harmed, dead, or lynched. And that is intergenerational trauma. It's when Black people currently are living in fear of camping or outdoor exploration because our ancestors were killed when they went into the woods or when they ventured too far. And so this enduring pattern is not pathological, it's protective. So the decision to not go camping or exploring is the natural trauma response to remain safe. But what has served to protect us in the past might now be distancing us from what could be most connecting and healing in the present. And our inherited trauma responses have an impact on what we do, where we go, where we feel safe, and where we don't. So if we look at Black people not going to the wilderness, sometimes this results in Black folks being disconnected from the land they live on, distanced from a powerful source of healing in the outdoors. And so the same is true when it comes to psychedelics. Black folks might see harm where others might see healing, and they have been so harmed by the drug war that there is a collective fear and avoidance of psychedelics. So intergenerational trauma really pervades the entire life experience for Black people, and we carry the trauma of our ancestors in our bodies today. And we live within systems and environments every day that we fear, and we carry an embodied stress because of that. In many spaces, the world literally isn't safe, and it hasn't been safe for centuries. And that oppression is internalized, and we're constantly in fight or flight, and for good reason, because this trauma isn't just historical, but it's also ongoing and contributes to severe stress individually and collectively for Black people. So what's clear is that people of color need healing, and psychedelics have the potential to support that healing. And people whose ancestors were traumatized and oppressed have internalized that. And psychedelics are unique in, I think, in their ability to help support the liberation of bodies and minds through helping people of color turn towards themselves with compassion and connect more deeply with themselves, their story, their bodies, their communities, and their history. And these medicines can help us honor that history, to honor our ancestors through connecting with the intergenerational wisdom, resilience, and strength of all our ancestors who endured so much. And both MDMA and psilocybin can be powerful tools to support that process. And we'll need more therapists prepared to work with psychedelics, as well as therapists who have the necessary training to support someone with race-based stress or trauma. Diversifying the field to include more therapists and researchers of color will also be necessary. And if we don't have providers who match the identities and cultures of our participants and clients, people of color will be much more hesitant to consider these therapies or studies, or may not feel safe, seen, or heard in the therapy space. But therapists of color are people of color and aren't immune from the impacts of internalized oppression and intergenerational trauma. And I know this from my own experience. I lived in the psychedelic closet as a clinician for over a decade and stayed away from this work out of fear. I wouldn't share about my experiences in any professional space. And I grew up in a household that hammered home the truth, which is that when it comes to drugs, I couldn't do what my white friends were doing. And, like one of the most regular things I would hear from my dad was, you're Black and you don't get warnings and you don't get second chances. And so that message echoes through the homes and communities of color across the country. And most of the time, we're going to do what's most safe. So we need more spaces for therapists and researchers of color to talk about psychedelics and get connected to this field. And that's happening. I attended MAPS training for therapists of color in 2019 and connected with other folks passionate about this work and living with similar experiences to mine. And in that space, I felt more courageous and vulnerable and more heard and seen and connected than I ever have before. And that completely transformed my career. It's a week I'll never remember. Forget, sorry. And so more trainings and spaces such as this are needed, but also building bridges to universities and developing training programs in schools that are minority majority, such as this university, the University of Baltimore, and historically Black universities and colleges. And all of these spaces can help provide the necessary training spaces for therapists and researchers of color. So again, for therapists out there, especially if you're a therapist of color, the time to start doing this work of supporting diverse populations in the field is now. And we need to begin building the foundation for a more diverse field and treatment population in the future. I'm not too familiar with Baltimore, but I did a little bit of research, and your university is extremely diverse. The population in the community is one of the densest like African American populations in the country. And so you're going to be working with population with unique needs, and probably a lot of folks who are struggling with depression, addiction, PTSD, but also internalized oppression, racial trauma, intergenerational trauma. And luckily, you do have a seasoned neighbor in Johns Hopkins who knows this work with veteran researchers and can support that launch. But every locale is different, and to be equipped to work with the folks in any community and to make treatment accessible to your city's population will need to involve input and feedback from the community. And researchers must be equipped to do the research that listens to the community and involves the community's input and collaboration. And there's tons of work to do. There's so many gaps in the psychedelic research, but that also provides opportunities for researchers to help fill those gaps. And the current reality is we don't know much about the attitudes or experiences with psychedelics for people of color, and because research is largely not included these populations. So without inclusion in their voices, there's a lot that we still won't know and need to learn about treatment approaches for diverse populations. So, qualitative research, I call it scientific listening, through interviews, focus groups, community-based participatory research. All of this can allow for the listening and learning from those in the community to understand their unique needs. But when engaging communities and outreaching, it's important that we recognize that this work is not missionary work. We can't assume the role of saviors and healers that can simply bring psychedelics and healing to communities. This work is relational, and it must be grounded in humility and mutuality. And as a field, we must move from the position of expert to learner when it comes to engaging to new populations, and from cultural competence to cultural humility. And just recognize how much we have to learn and how much we can be informed by those that we're connecting with. Connecting with people where they are in ways that are safe for them. So this path moving forward needs to involve research and science that has woven into it community collaboration, equity, and social justice. Connecting with community organizations, leaders, spiritual centers, and building relationships with those in the community where trust and safety are already established. And if communities are empowered to participate in defining the methods and practices that are safe and effective, they'll do that. And we need to be aware that sometimes this won't reflect some of the current approaches in the field. And who knows, there may be a need to develop new models, new approaches, and new studies that are centered around the needs of people of color that allow them to feel more safe and can provide healing and reduce harm. And our current models of care and approaches in therapy have not always worked for people of color and have not always been informed by their voices or built to address their specific needs. I think it was Rick who mentioned the group therapy approach. Looking at that, it's very much needed. And because from the therapy session to the integration, there's so much to be desired outside of the one-to-one therapy, which often leaves many needs unaddressed, especially for folks of color. And so what happens when a person returns to their community and returns to the spaces that traumatize them, right? So for the field, changing the way that we do things will come with discomfort, but like any psychedelic experience, we should be curious about that discomfort and be with it and explore what's there and allow ourselves to learn from it. So to know where we're going requires us to know where we've been. And like I mentioned before, we all have a story. And when we connect with our story and we can see how our story is situated within our larger collective story, things began to make sense, and we deepened our capacity to do the work of connecting with and supporting diverse populations. It's important that we recognize the story that psychedelics have also, and what we learn if we look into the history of psychedelics. We find this really long, rich history. For millennia, these medicines were an integral part of the healing practices of many indigenous cultures across the world. But there reached a moment in history when indigenous cultures and their use of psychedelics coincides with European colonization, where you see the systematic extraction of resources and conquest of land work side by side with the uprooting of Native people from their culture and traditions. So I shared a bit of my story earlier, and with colonization, two different worlds collided, and today, two very different worlds still remain. And many people are still scarred and wounded by the past and disconnected from themselves, their cultures, and their ancestral traditions with these medicines. So this is part of our story. It's the story of psychedelics, it's our history. The future is what we make it, and we could build a future together if we're intentional about it. But to move forward without seeing each other and listening to each other, and without bringing down the barriers between us, will keep these two worlds apart. So the future of the field will be a test of what we care about and what and who we're prioritizing. And I have a vision of a field that is reoriented to prioritize the needs of people who are not currently accessing treatment or who are currently unaware of psychedelics and who need treatment the most. I envision a more diverse and inclusive field that has embraced a much greater commitment to equity and social justice. And there's a ton of individual healing and transformation personally happening. But if we're going to support our collective healing or collective transformation, movements for social justice and the psychedelic renaissance must see that they are not separate, but intertwined, and that personal wellness and collective wellness are always interconnected. So as we move forward, social justice and equity must be embedded more deeply into all that we do in this field. Just to wrap up, I'm gonna quote an amazing author, Adrienne Marie Brown, in saying, we are each other's medicine. So while we're looking at psychedelics to help heal conditions such as trauma, PTSD, addiction, we must see that we also have the power to help heal each other, and we need each other as part of our healing. And trauma and depression and addiction are happening for people within their environments and within these systems. And they're living in, and the environments they're living in are those that are often creating the conditions where more people are experiencing trauma, depression, and addiction. Addressing that is part of our healing also. And each of us have the power to support policies that help build systems and communities that leave people less traumatized. So we know that psychedelics are powerful medicines, but we are also each other's medicine. So committing to doing our own anti-racist work and social justice work by activating our power to be a part of the transformation needed at all levels and across systems, from justice to education to employment to healthcare, law enforcement. I truly believe that as we move forward, if the movement is going to be a movement grounded in social, that the psychedelic movement needs to be grounded in social justice and equity. With that, we can help transform more lives and help transform our society. Thank you.
Great. Thank you so much, Joseph, for that terrific talk and for the important work that you're doing. So it's 9 o'clock by my clock, so that does sort of take us to the end of our allotted time. Fortunately, there's been quite a lively Q&A discussion happening, and so people have been participating in that, and I see Rick Doblin's been working overtime to answer a lot of questions in there, so thanks for that. And we will be able to answer more potentially later via email as we have time to review them. I do have one question that I'd really like to ask quickly before we end, though, and it ties into some of the questions others have been asking. A few people, brought up whether there might be like a risk of suicide in the time after the treatment, and then I also heard the term afterglow used. So I'm kind of curious, like, how important do you think that the maybe week or two following the treatment session, like how much happens then after the session, but over the next week or so? How important is that? And is there any risk associated with that? And that question is for anyone, Rick, Matt, Joseph.
Okay, well,
I think it's incredibly important. We need to figure out more of the details, but just, the impression is like when it works, there's an incredible opening, and it is a period of vulnerability. And so if someone's, you want someone in safe circumstances in those days following their session as much as possible to be able to process. But it's, yeah, beyond that, I don't know what to say. My impression, it's really important. There is an opening there.
Yeah. I'd say that the main distinction between a recreational experience with psychedelics and a therapeutic experience with psychedelics, in that recreational, people are looking for what happens when they're under the influence of the drug, and that's basically it. In therapy, we're looking for what they bring back afterwards to change their baseline without drugs. So that week and the months afterwards, the integration process is an essential element of the therapy. And our goal, unlike SSRIs, is to make people bring them to a place where they don't need these drugs for therapy. So that is what the integration process is afterwards, is try to anchor what happened during the experience and then make it so that they can integrate it in their lives and go forward in a different way.
I'd like to just mention something as somebody who's went through the process on the other end, and not to say that you guys haven't, but the week and months after I had my treatment is it was all positive totally, and I mean I felt alive and I felt wonderful, and man, I wanted to live to be 125.
Okay. Thank you. Well, I think this has been a fantastic event. Clearly things are happening and there's a lot of work to be done, but people are working on it, and I'm pleased to be a part of that potentially. So thanks again to all our attendees, to everyone who participated in the chat and the Q&A. Thanks so much to Rick, Matt, and Joseph, our phenomenal speakers. Thank you, Bob, for your support and wonderful words at the beginning. Thanks, Wes, for sitting in, Dean Spencer, President Schmoke, Dr. Eisel, many thanks, and we hope to continue this relationship going forward. All right, thanks everyone. Have a great night.